and as you will see, we have got quite a packed agenda today. I'm going to take you through the first part, and then we're going to hand over to Caitlin, who is going to take us through the urgent community response data findings. Then we're really lucky to have Louise and Sadie from Age UK, who are going to be talking about the hospital avoidance response team, followed by myself, who will be going through the services provided at home findings, and then passing over to Shauna, who is the Chief Pharmacist for intermediate care over at Belfast Health and Social Care Trust, to talk about the role of pharmacists in intermediate care. Then Lily's going to take us through those bed-based findings, and then we're going to be joined by Kevin from Norfolk Community Health and Social Care to see how they're using the benchmarking findings over at Norfolk. So as you can see, a packed agenda, quite a diverse agenda, and hopefully something for everybody. And I'm really pleased to see that the chat is going off in the background and everybody's introducing themselves. That is brilliant. So I'm just going to start with a little bit of an overview and introduction to who we are at NHS Benchmarking Network. I'm sure most of you will have heard of us before or have heard this from me previously, so I will keep it short and sharp. So we are a membership organisation, and we are here with the vision to help improve patient outcomes, raise health standards, and deliver sustainable quality health and care services through data excellence, benchmarking, and shared innovation. And I'm really pleased to be able to say that we're actually going into our 30th year this year, which is a huge achievement and dedicated to all that membership that we've had over the years. And that vision has remained constant through all of that, as have our values: excellence, respect, and integrity, which I am sure resonates with every single person on this call. So I'm going to just move on to about what we do and how we do it. And what do we do? So in essence, and I'm going to make it sound really simple, I do appreciate it isn't this, but this is at a really high level. We source data, whether that is from nationally available sources, which is used in some of our indicator projects, or like in this project, we collect it from our members, and that's where it's really valuable because that is your data. What we also then do is we curate that data, so we cleanse it and we validate it. And one of the unique things about us at the network is we go through 2 rounds of validation where we play that data back to our members and give you the opportunity to confirm that that's right. So we have confidence in what we're playing back. I'm going to say we analyse the data here. I have to say it really is the royal we. It is the team that are on the call today that do a lot of that work. They benchmark it, they describe it, and they model it. We then visualize it, whether that's in toolkits or reports. And if you are a participating member, I really, really encourage you to go and look at your member reports and your toolkits that are accessible on the members area now. If you haven't done that, one of the team is going to drop a link into the chat so you can access that. If you need a login, please reach out to one of us. We would be absolutely delighted to set that up for you. And then our final part, we collaborate for the insights, and that's where the real power of the network comes during these sessions, but also that connectivity with other members to allow us to drive those improvements and improve patient care. I'm just going to do a really quick summary of some of the other stuff we've done, because I've talked an awful lot about the membership programme here, which is what our intermediate care project is part of. But we also have a number of other products and services. It says there over 25 years. As I just said, we've moved into our 30th year now, where we have lots of experience in doing that bespoke analytical solutions to help organisations translate data into meaningful insight to help both strategic and operational decision making. We currently are running a workforce programme because workforce is the heart of everything that happens, and ensuring that you have the right size, the right people and the right skills is really that essential to meeting that demand. And we've currently been doing a benchmarking exercise with NHS England, looking at NHS, VCSE, LAs, offering that for mental health services. And then, as if that isn't enough, we also have a programme of national audits, CVD Prevent you may have heard of, or the National Audit of Care of Life, or the Learning Disabilities Improvement Standard. So a huge range of things happening over at the network. So just moving on, this is actually this year's current member programme, but I'm really pleased to be able to share that we're going to be running the same programme in 26-27 to allow that continuity and allow that benchmarking and help to measure some of those improvements. So we have our monthly projects, the national indicators and acute indicators, which pulls from nationally available data. So there's nothing that needs to be submitted for those, and that allows you to see that month-on-month trend. We also have our community and our mental health, learning disabilities and autism indicators, which runs on a monthly basis again, but they are collected from members. We then also have different data sets for different sectors. So let's focus on community because that's what we're here about today. We have our district nursing, our adult and children community services, and intermediate care, which we're here for today. We also have mental health projects looking at adult and older people, children and young people, learning disability specialist services, and this year we ran a pilot on mental health pharmacy. We also have acute projects and also a number of cross-section, including emergency care, managing frailty in bed-based settings, and virtual wards or hospital at home, depending on where you are based in the UK and what it is called where you are. Now, the majority of our projects are built up from service or ward overviews, but we do have a number of other mechanisms to collect data using surveys which are used in intermediate care. We have our clinical case review, which the team will be touching on some of the findings from as we move through, and they include more granular data of a smaller cohort of patients, which allows us to really understand some of those outcomes. We have a staff survey, which is really interesting and provides some valuable insight into those areas. And we also have the patient reported experience survey. So we really do have a wide range of services and surveys that we can pull that information from. I'm conscious of time, so Caitlin, I will do my last slide before I hand over to you so I don't steal all of your thunder. So when we were coming together to pull this event today and what we were going to present, as you can appreciate, because of all the different mechanisms that we use to collect data, there was so much information that we could have played. So we tried to pull it back to some of the 10-year health objective and the links. So, and I think everybody's doing this. I know this is linked to NHS England, but I think this is transformational across the place. Community care shift everywhere. I know it's happening in Northern Ireland. It's all about that community shift. That workforce development, there is only a finite number, so we need to make sure that we are using the resource and the most valuable resources in the right place. Digital integration, we live in a digital world, so we're going to focus on some of those, and those strategic health goals as well. So that is a little bit of where we want to take you on this journey with us today through the intermediate care findings. And I'm really pleased to now hand over to Caitlin, who is going to take us through our urgent community response findings.
Thanks, Sarah. Good afternoon, everyone. Thanks for joining us. As Sarah said, I'm going to kickstart things today by going through the data that we received around urgent community response services. And just as a piece of information, in this year's project, we received data from 34 urgent community response services across the UK. So we'll begin by looking at the overall demand for urgent community response services. So starting with referrals, the median service this year received 4,165 referrals, which equates to around 79 per week. And although the consistent sample data shows a small reduction of fewer than 300 referrals when we're comparing with last year's data, the broader trend since 2021-2022 continues to move upwards, indicating sustained growth in demand. Of those referrals received, 66.7% went on to receive an assessment, with the median service reporting an average waiting time of 2.19 hours from referral to assessment. This year, referrals came from a wide range of sources, including GPs, community teams, ambulance services, NHS 111, and self or carer referrals, which reflects the diverse access routes in UCR services. As highlighted on the slide, 85.8% of referrals were classified as step up. This high proportion underlines the critical role that UCR continues to play in supporting people safely at home and reducing avoidable hospital attendances, an important national priority as the system shifts activity away from acute settings. Finally, the data from this year shows that 96.4% of services are accessed via a single point of access. This supports smoother triage, improved responsiveness, and greater consistency across referral pathways. Let's now look at UCR services and how they're performing in terms of response times and what happens once care ends. So starting with the 2-hour target, we can see that 88.8% of referrals were assessed within 2 hours. This is a really strong performance and shows that services are consistently meeting the national expectation for timely crisis response. In fact, on our toolkit, you can see that all participants hit the NHS target of 70% of referrals being seen within 2 hours. And then looking at duration of service, the chart on this slide shows how wide the variation is between individual services. Some services are providing relatively short episodes of support, while others deliver significantly longer periods of input, upwards of 100 hours in some cases. However, the median duration of service was reported as 45 hours. The duration of service has fluctuated slightly over the past 4 years, however, only minimally. The PREM feedback, which is feedback from our patient-reported experience measure surveys, also highlights the experience of care. 89% of patients felt involved in decisions about when their care should stop, and 82% said staff discussed any ongoing health or social care needs after the UCR involvement with them. This reflects strong patient engagement and good communication at the point of discharge. Now, if we look at destination and discharge, we can see several positive trends when comparing last year's data from 2023-24 to this year's data from 2024-25. Firstly, more patients are returning to their usual place of residence, rising from 55% to 62%. This indicates that UCR services are appropriately targeted and providing effective support that enables patients to stay safely at home. And although we did identify that 7.4% of referrals were classed as clinically inappropriate for UCR services, this still remains a small minority of the referrals received and suggests referral pathways are largely functioning as intended. There's also been a notable increase in discharges to residential or nursing homes, rising from 1.5% in last year to 8.8% this year, suggesting that for some patients, longer-term care needs are being recognised and acted upon appropriately. At the same time, we're seeing reduced reliance on acute hospitals and virtual wards, with acute hospital discharges dropping from 6.7% to 5.4%, and virtual ward discharges falling from 5% to 3%. Finally, we should highlight improvements in data quality. The proportion of cases recorded as not known or not recorded has dropped from 29% to 18% this year, giving us much clearer insight into patient pathways and strengthening the accuracy of future planning and evaluation. So looking more deeply into the PREM surveys, when we look at the experience of patients and the UCR services, the feedback is exceptionally strong. One of the clearest messages is that people feel the service works around them. Patients are saying the visit times fit around their routines and that staff are arriving when it genuinely works for them, which is often one of the biggest factors in how supported people feel at home. Another really important theme is dignity and respect. Every single respondent to our PREM survey for the UCR services told us they consistently felt treated with dignity throughout their care. For a service that's often responding to people at some of their most vulnerable moments, this is hugely significant. Communication also stands out as a real strength. Almost all patients said that when they had questions or needed clarification, the staff took the time to explain things in a way that made sense. That tells us the team is not just delivering clinical care quickly, but is also building trust and understanding with patients. And finally, patients are telling us they feel involved in the decisions about their care. So overall, these results show a service that's not only responsive, but genuinely patient-centred, respectful, communicative and supportive at every step. So jumping into the workforce, we're going to start looking at the size and the makeup of the UCR workforce this year. So what we can see here is the scale of staffing relative to demand. For every 100 new assessments, services have just under one whole-time equivalent member of staff in establishment. When we look specifically at nursing, there are just over half a nursing role per 100 assessments. This gives us a good sense of the size of the teams delivering UCR activity. Looking at the discipline mix in the chart on the right, UCR continues to be heavily nursing-led, supported by a wide range of allied health professionals, such as physiotherapists, occupational therapists, and paramedics. This multidisciplinary blend is fundamental to the 2-hour response model, ensuring that patients can receive the right intervention at the right time. It's also reassuring to see that 79% of staff feel fully or adequately supported and equipped to handle emergencies. For a service that often responds to people in crisis, that level of confidence is really important. Moving more closely into the nursing workforce, we can get a better sense of how the teams are structured. Registered nurses make up the largest proportion of the nursing group, bringing the clinical leadership needed for rapid assessment and decision making. They're supported by unregistered nursing roles who provide essential day-to-day care and help maintain a responsive service. There's also a smaller contribution from advanced practitioners who bring additional clinical expertise. When we look at the band mix, Band 3 staff form the largest single group, and Band 6 nurses also feature strongly. This combination of skill support and experienced clinicians underpins the flexibility the service needs. And despite the pressures the workforce is facing, morale around impact remains extremely high. 97% of staff agreed that they felt their role makes a difference to patients. That's a strong message about professional pride and purpose. Of course, the workforce picture wouldn't be complete without acknowledging the pressures underpinning it. Vacancy rates this year are similar to last year overall, but the range is extremely wide, from organisations reporting vacancies of 33.3% to others showing staffing levels 12.4% above establishment. That level of variation tells us that while some teams are operating with significant gaps, others are able to staff above their planned baseline. At the same time, sickness absence has increased, rising from 4.9% last year to 6.5% this year, which naturally adds day-to-day pressure for teams delivering a rapid 7-day response. It's also important to note that the UCR vacancy and sickness absence rates sits above the NHS average, which can be seen from the data in the table. This reinforces the pressure many teams are experiencing in attracting and retaining staff. However, despite these challenges, staff wellbeing indicators remain strong. 76% of staff that answered our staff survey say that working in these services has positively impacted their work-life balance, and 95.8% feel able to meet all the requirements of their role. Overall, these findings mirror many of the themes within national guidance: the need to build and sustain multidisciplinary community teams, support staff wellbeing, and maintain high quality care despite ongoing workforce pressures. Turning now to the financial picture, this slide gives us a sense of how resources are being managed within UCR services. First, we can see that total staff pay spend per 100 new assessments is just over £43,000. Alongside this, organisations collectively show an underspend of 3.4% when comparing their pay budgets to spend. However, the range is wide, from 17.9% overspend to 65% underspend. That variation tells us that services are operating within quite different local financial environments and models of delivery. It also reflects the range in vacancies that we saw on the previous slide. Now, if we look at total direct costs, these sit at just under £53,000 per 100 new assessments, and non-pay spend shows a modest rise at £2,874 per 100 new assessments. Given the national direction of travel, delivering more care closer to home, an increase in community-based consumables and equipment is not unexpected. One additional contextual piece of information is the median budget change planned for 2025-26. Organisations reported a 3% increase in pay budgets and a 2% increase in total direct cost budgets. This indicates that systems are planning for modest growth in investment next year, which aligns with national priorities to strengthen community-based services while keeping financial discipline. Finally, one of the most positive shifts shown here is the reduction in reliance on temporary staffing. Bank and agency pay as a proportion of total pay has fallen from 7.8% to 4.8%. Reducing agency is a core NHS aim because it supports continuity, quality, and long-term sustainability. Seeing this move in the right direction, despite workforce pressures, is a strong indicator of maturing service models and more stable staffing structures. So overall, the financial picture points to a tighter cost control, strategic planning for modest growth next year, and encouraging reductions in bank and agency spend, all while continuing to deliver a rapid at-home crisis response service. Finally, we're going to look at digital integration, and this slide tells us a lot about how well UCR services are connected in the wider health and care system. Started with shared care record access, we saw that the access levels are high overall, with 93% of services reporting that they have some form of access to a shared care record. That's really important for UCR because being able to quickly view accurate and up-to-date information supports safer assessment and helps clinicians make informed decisions when responding to urgent situations in people's homes. What's particularly encouraging is that when we look at the consistent sample from last year, the number of services with read and write access has increased. That's a meaningful step forward, moving from simply viewing information to being able to contribute to it, and helps improve continuity of care, supports integrated working, and aligns fully with the NHS ambition for shared interoperable records across systems. However, despite this improvement, the majority of services still only have read-only access, highlighting that there is still progress to be made in fully enabling two-way information sharing. The chart on the right reflects staff perceptions of integration with other healthcare services. The majority, around 2/3, feel urgent community response is adequately integrated with, and another quarter feel it is very well integrated. This suggests that from the frontline perspective, UCR is increasingly embedded within the wider urgent and community care landscape. The staff survey responses do still point to challenges, as seen by the quote in the yellow speech bubble. For example, a sense that external partners may not always fully understand the purpose of UCR, but the fact that no respondents reported being poorly integrated or not integrated at all is positive and suggests a strong foundation to build from as ICSs continue to join up pathways. Overall, this slide shows improving digital connectivity, increasing read-write capability, and a workforce that largely feels UCR is operating as part of a connected system. Strengthening these links further will be key to ensuring UCR continues to deliver timely, well-coordinated care across the whole pathway. And that brings me to the end of my section. Thanks for listening. Sorry for waffling at you. And I'm just going to hand over back to Sarah now.
That's great. Thank you so much, Caitlin, and really useful information there around the current state in the UCR from the findings. There was one question, or I suppose comment in the chat around the expected to have seen more step up to virtual wards based on what they're seeing in their own patch. If anybody has any comments on that, please feel free to drop those into the chat, as this is where part of the shared learning. I'm now delighted to be able to hand over to Sadie and Louise from Age UK to share some of the fantastic work they're doing on the heart service, I believe. Have I said that right, Louise? Hospital avoidance response team. So Sadie, you should have been made a presenter now, so you should be able to take yourself off mute and show your camera.
Sadie here. Shall I just introduce her first? Can you hear me? Oh, there she is. Hello, Sadie. Before I bring Sadie in, I just want to say a little bit about why I'm here. My name's Lou Jackson. I'm a policy manager from Age UK National. I'm really pleased to have been invited to come along and talk about some of the things that Age UK, our partner Age UK do. but I'm not the expert, which is why Sadie's here to talk about the service that they provide in Lincolnshire. So we've got 109 local Age UKs operating in England. They all do a variety of different wonderful things, and I'm always impressed when I go out to see the work that they're doing, impacting older people, helping them to get out of hospital faster. As a lot of the services that our partner Age UKs provide sit in the intermediate care space. This service actually has a UCR element to it as well, doesn't it, Sadie? Although that's not what we were going to focus on today. When we were asked if somebody would come along and talk about the different things that are happening, I immediately thought of Lincolnshire, because my colleague and I had been to see Sadie and the work that they do, and it was so impressive. So Sadie, I've got the slides. I hope I haven't chopped them off at the wrong point. So if you do a next slide, please, on me, and I'll just move them along so that you can talk a little bit more about the heart service in Lincolnshire and the difference it's making to people in the Lincolnshire area.
Absolutely. Thanks, Lou. So I'm Sadie. I'm the registered care manager for Age UK Lincolnshire. I'm really looking forward to sharing a bit about what our hospital avoidance response team do. The next slide, Lou. So the response team was established back in 2015 by our particular Age UK partner, which was back then Lincoln and South Lincolnshire, and it was commissioned by the Lincolnshire Community Health Services Trust. We've been really fortunate to have the contract extended and recommissioned over those years, and we've currently got just over 40 staff members across Lincolnshire that work the heart service. We have got 5 different locations across the county, but it's very every single member of staff is just happy to go anywhere in the county where they're needed to help these hospital avoidances. Thanks. Next slide, please, Lou. So it sounds really simple and straightforward what we do, if only, but ultimately we help reduce admissions to hospital, and we help prevent admissions. So we help speed up the discharges. So, for example, it might be that there's a patient in one of our local hospitals that is medically fit to go home, but they haven't got a care package in place, and it might be a 2, 3 or 4 day delay. What we do is we step in and we provide the care, so we bridge the gap of care until that care package can come in and look after the client long term. So it helps get that person out of bed sooner rather than them stay when they're actually medically fit to go home. And on the flip side of that, we also prevent admissions, which is where we work quite closely with the UCR team. So this could be a typical example, could be that somebody has a urine infection, for example, and they are showing signs of confusion that they wouldn't normally display, and it might be that they're not quite safe on their own at home until the antibiotics have kicked in. We would take a referral from the UCR team or community nurse, and off we would go, and we'd put in 3 to 5 days care until that person was independent again. Next slide, please, Lou. I think I've really covered that slide. I never read off slides, I just go off on a tangent. But we can see there that we work really closely with the emergency services. We get a lot of referrals through EMAS, which is really good. We get referrals from A&E. So there's a lot of people, medical professionals and adult social care professionals that do send referrals our way. Next slide, Lou. So this is the bit where it gets a little bit of a grey area sometimes, but the hospital avoidance response team itself, if somebody is in hospital and they are being discharged, we provide up to 72 hours support at home. On the flip side, if somebody's already in their own home, it's 5 days. But as you can imagine, it's never quite that straightforward. You know, if we have somebody come to us and they've got a package of care in place, something might come and go amiss with that care package. We're there until they're safe. So we make sure that we don't pull out of any of our services. So it's a bit of a, it's always quite fluid, that 72 hours or 5 days. It should be that. But, you know, at the end of the day, we're just looking to help as many people as we can avoid going into hospital or coming home to help them get better much sooner. Next slide, Lou. I've already covered this one. Unfortunately, we can't. Unfortunately, oh, no, sorry, Lou, it's me. Unfortunately, clients or members of the public aren't able to refer into our services. It is only members of hospital discharge teams, community nurses, GPs, adult social care. So they have to be a medical or social care professional to do so. You can see there's lots and lots of support that my service can provide. And I've had to put the one at the top, the one to me that is the most important, and it's about empowering and enabling. We don't go in to do for, we go and do with, because somebody's come out of hospital and we're helping them regain their independence, or on the flip side, we're helping them to maintain their independence. So we do most things that you know, the average care company, community care company would provide. We do provide medication support. One of the things that you can see there is we do also provide a temporary telecare and response service. So all of my staff within the team are first response first aiders and are all trained to use the Manga-ELK, a lifting device, which we use following a post-falls assessment when we've been called out to somebody that may have fallen. And that's on top of our, that's part of what we do within that service. And it's free, of course, while people are with us. We signpost to other services. We've got many services within Age UK. Mine is just one of them. So there's lots and lots, and we refer to external agencies if we need be. Lots of close working with adult social care and community nurses, physiotherapists and things like that. But everything from mobilising to meal preparation, medication and personal care, we pretty much do most of it. Next slide, Lou. This was just a slide that actually I had in from another talk that I did, and it was just about how do we personalize our care? What do we do in order to make that happen? And it's just a bit of an overview there of what we do, and just things like, of course, we share the decision making with the client. They're involved from the start to the finish, and even though it's just a short-term service, yes, we do have care plans from that very first visit. Because of the speed of the discharges, all of the staff are trained to carry out those initial assessments. So their first care call and support call, if you like, starts on that first visit following exit from hospital. And we tend to meet with gauge it, so we're there as they're discharged where possible. We get lots of information. Sorry, Lou, we have lots of info from the referrers and things like that, and yeah, there's lots of ways that we personalize. Thanks, Lou.
Bit trigger happy there, sorry.
Yeah, that's all right. This you more than likely won't, many of you on the call, I mean, we're all over the place, aren't we? But that's the way that people refer into our service. We have actually in the last month stepped into the 21st century, and we've now got an online referral system too, which is rather exciting. And you know, it's just the professionals call through, we check our capacity, and if we can meet those persons' needs, then we will fill that gap to enable them to get home. That's it. Oh no, this is the data. So I did just pull the data together for you for the whole year of the financial year 24-25. And just to give you, I broke it down into the hospital discharge, the avoidance and the UCR element. And you can see there, I don't wish to read it all out, that you can see it on there, the quantity of people that we supported. I mean, I just think it's lovely to have been part of helping 646 people across our county be discharged from hospital when they were ready rather than been delayed. Thanks, Lou.
Thanks. There's two more data slides, but I can. Do you want to see them both, or
please, if that's okay?
With our time up. Oh, of course.
And then the avoidance, again, nearly as many people supported, but we saved just under 3,500 hospital bed days by supporting those people to stay at home. Thanks, Lou. And the last one, our UCR element. So we supported 329 people that were referred to us through UCR. And again, saving 1,000, just over 1,700 hospital bed days during that financial year. Thanks, Lou. All of it together, of course, saves us there you go, the overall saving for our NHS. I'm really proud to say, it was over 4 million and over 1,500 people supported, but over 14,000 hospital beds saved. So we're really making an impact. So thank you very much for Lou inviting me on to help you with this today. Thank you.
That's amazing, Sadie. There are 2 questions in the chat, if that's okay. One of them was from Stephen in Croydon. Is there a limit of the number of patients that you can have on your caseload at any one time?
No.
Amazing. Nope. And then the final one is from Andrew. I'm not sure where Andrew is from, but it asks around what professional does the post-fall assessment?
So our post-falls assessment has been created with the UCR. We work very closely with the UCR team in Lincoln. So they are called a first response responder, community responder. They've got several names, but a responder. They're responding to calls, but they're trained to. So it's not. As in terms of what profession, it says what profession, but what if it's in terms of the person who does it, it's one of our responders, and the post-falls assessment has been carried out with the UCR team.
Amazing. Thank you so much, and thank you for taking the time.
So sorry, Andrew, you've just said a nurse or a HCA. So it's neither of those, but a responder would be equivalent to a HCA, maybe a high level HCA.
And there's one final question, and then I am going to move us along. But if it's okay, ladies, I will share your contact details in the chat if anybody thinks of them later on. Apologies to be the time, please. Just conscious we have a lot to cover today.
Yeah,
but the question was, do you have a reablement service in your area also?
We do. We have a couple, and still we're that big on what we're doing to help. Yeah.
Amazing. If you could drop your contact details in the chat, that'd be amazing. And thank you so much for taking time out of your really busy days to come and speak today. I hope it's been helpful for everybody on the call. And I hope you'll stick around for some of our other findings we're going to share.
Thank you.
You're stuck with me, I'm afraid, for the next section, and I am going to sort of link on to some of that we've been talking around those intermediate care services provided at home. And again, like Caitlin, we're not just going to talk about activity, but we're going to look about what that relates to in terms of flow, outcome, integration, and staff experience. And as we've touched on multiple parts of the session today, home-based intermediate care is critical enabler for that policy direction, supporting people to remain independent, avoiding unnecessary admissions, and as Sadie's just touched on, accelerating those discharges. And what this data set allows us to do is to move beyond the anecdotal and start to look at where those services are working well, where pressure is building, and where there's opportunities to intervene earlier, and also to have a look at how this works with aligning to the hospital to community shift set out in multiple different policies from different regions, and exploring today whether that capacity, access and workforce is able to keep up with that ongoing ambition. So I'm going to start by looking at where a bit of a service overview, and the majority of the services captured here are home-based intermediate care models, with a smaller number that are reablement or fully integrated MDTs. And when we look at how those services are organised, just over half were delivered as standalone intermediate care teams, with a growing proportion actually embedded within neighbourhood or community integrated care teams, which is positive as that does mirror the shift towards that neighbourhood working. Now, geographically, most of these services were operating in either an urban or a mixed setting, with limited rural representation in this data set. And I think that's important to note, as often the challenges can be very different in rural settings, so it may not be fully represented in this data set. And I think it's fair to say that demand is clearly rising. The median service received around 4,100 referrals last year. Now that translates to nearly 78 referrals per week, and that is an increase on previous years. But what's particularly noticeable is about where some of those referrals are coming from. Over a third now originate from acute settings, with emergency set referrals also rising. And at the same time, GP and community service referrals have actually started to decline, while self-carer and social referrals are increasing. So this begs the question, is there an opportunity to potentially intervene earlier and potentially strengthen that front door community access to reduce the escalation before crisis actually hits? So despite that rising demand, services are maintaining a strong performance in terms of triage and appropriateness. Over 80% of those referrals were converted into assessments, equating to approximately 60 new assessments, per week. And that suggests that teams are doing a really good job at filtering referrals and focusing effort on where it can really add value. Even more encouraging is the trend over time. The median time from referral to assessment has steadily improved from over 4 years, from falling from over 5 days to around 3.4 days. So this aligns with those national ambitions for responsiveness of community services and indicates that there's a real operational improvement happening here. However, once assessed, I think this is where we can start to see that some of that pressure is starting to show. Over 40% of services reported a gap post-assessment prior to service commencement. And I suppose that links really well into what Sadie and Lou were just talking about. And the median time from referral to service commencement is just over 3 days. And over half the patients are waiting more than 2 days for services to start. Now, this is a deterioration compared to last year, and it's likely to reflect those capacity demands rather than those triaging issues, most often due to workforce availability or equipment delays. And from a patient perspective, delays at this point could really undermine the confidence in the home-based pathway. But probably more significant, it could increase that risk of deterioration or a potential readmission. So looking at outcomes a little bit here, and the median duration of service sits at around 24 days, which is very much within that expected operating range of intermediate care. And importantly for me here, is where most people are being discharged to, and it's our usual place of residence, which is reinforcing that role that these services are enabling independence and supporting that hospital flow. There is some year-to-year variation, but there's no evidence of uncontrolled lengthening of packages, which can often be a concern when services are under pressure. Now, for me, this is probably the most powerful slide when we come to look at outcomes, and this data is taken from our clinical case review. As I mentioned earlier, that's where we take you, the members, take a cohort of patients and collect some more granular detail. And what we do is what we do is we capture that data of a patient's acuity as they enter the service and again as they access it. So a real measure of the impact the service has had. And what we can see is there has been a reduced dependency during that time, which shows that intermediate care is doing exactly what it's designed to do. Now, noticeably this year, what we've noticed is people are actually entering the service more acute, supporting that accelerated discharge. But what it's actually doing, it's showing is that they're still leaving the service with the same level of dependency as last year. So they're actually having a bigger impact when compared to last year. And sticking with that, on the impact it's having to patients, over 50% of service users were discharged with the same or a reduced care package following an episode of care, meaning that the service has either stabilised independence or in some cases actively improved it. So this suggests that the national priorities around deconditioning prevention, particularly for those older people following an episode of illness or a hospital stay, are being achieved. So I was just checking the time. I'm going to try and move up a little bit so we don't run too late. So if I speak too fast, please let me know and I'll try and slow down. I mean, patient feedback is overwhelmingly positive. Over 97% felt that the wait to start a service was reasonable, which is really interesting given the fact that I've literally just been speaking about over half of the service users waiting over 2 days. Dignity scores remain consistently high, above 95%, which is a strong endorsement about that relational care being delivered. And where some of those scores are slightly lower, such as involvement in decisions about when care is going to end, this might reflect some of the apologies, I've lost train of thought, complexities, apologies, that was the word I was looking for, of uncertainty and transition around dissatisfaction. But overall, I think this tells a really, really positive story that even under pressure, that care is remaining patient and person centred. So the workforce profile shows that AHPs are carrying out the majority of the delivery, which you would say is appropriate for rehabilitation focused models. Staffing per 100,000 new assessments has increased compared with last year, particularly among those AHPs, while nursing and non-clinical roles remain comparatively limited. Now, interestingly, there is very little or no medical staff embedded within the majority of these services, which does create that greater importance on MDT working and having clear escalation pathways. Now, vacancy rates sit around 12%, which is higher than last year, and sickness absence rates at 5.6%, again above the NHS average, while turnover broadly mirrors that national average. So taken together, this suggests that there are stable teams under strain rather than systematic failure, but it does raise a question around sustainability, apologies, and if that demand continues to rise. So again, taking some staff survey results here, and staff are highly motivated. 100% believe that their role makes a difference, and over 80% reported that moving into intermediate care had a positive impact, or being in intermediate care had a positive impact on their well-being. However, only 50% felt that they were supported to manage an emergency or an unexpected situation. And integration scores are average rather than excellent. And I think that really reinforces that sense that teams are holding systems together through goodwill rather than seamless processes. And maybe that's an area of potential improvement. So just moving on quickly to some of the spending, and spending per service user remains broadly within that budget, with actual spend coming in slightly lower than planned. Almost 96% of costs relate to pay, which means that efficiency and gains are more likely to be achieved from pathway and productivity improvements rather than from cost cutting. And this supports the case in investing in workforce support rather than squeezing already lean non-paid budgets. And you'll be pleased to know I've got only 2 more slides and then I can hand over because I know we are running slightly behind time. So again, I've taken a lot of this frailty data from our clinical case review, and just under 60% of service users were screened for frailty, which shows progress from previous years, but it also shows that there is room for improvement. Now, the frailty information is shared most consistently in community services and with GPs, but much less so in those acute settings and social care. And given the national emphasis on frailty-informed pathways, improvement in this data flow could significantly strengthen that continuity of care. And finally, sticking with that integration and broadly functioning, it's broadly functional, I would say, rather than seamless. Around half of service users receive their frailty assessment, and the shared care records access is variable. So the opportunity here is clear, I think. Better information sharing, clearer ownership, and stronger place-based coordination could really unlock impact without increasing the demands on our on the frontline teams. I haven't seen if there are any questions in the chat. Lily or Caitlin, is there anything that we need to jump to?
Nothing so far.
Nothing so far. So in the interest of time then, I'm going to pass over to Shauna, who's from Belfast Health and Social Care Trust and is going to share with us the role of pharmacists in intermediate care services. Thank you, Shauna.
Thanks, Sarah. Hello, everyone. My name's Shauna. I'm the lead pharmacist for intermediate care and the home-based services in the Belfast Trust. So I'm just going to talk through a bit about my role this afternoon. So a pharmacist was only introduced into the intermediate care home-based services in November 2023. Before this, there was already a team of pharmacists working within the bed-based intermediate care teams, but there was no one in the home-based teams. And the reason the Trust considered recruitment of a pharmacist was the staff were struggling with medication management for some patients because their medication regimes were becoming very complicated due to an increased prevalence of polypharmacy, an ageing population, and the availability of some more specialist treatments for long-term conditions. So a pharmacist working as part of the multidisciplinary team can help with complex medicines adherence issues. And offer solutions such as deprescribing and rationalisation of medicines to complement the work being done by the rest of the MDT. So I work closely with the multidisciplinary teams in the Community Rehabilitation Service, the Reablement Service and the Community Discharge Service. I also work closely with the Medicines Optimisation and Older People Pharmacy team for peer support. And the role involves completing home visits for medicines adherence reviews, delivering medication management training and reviewing medication policies. So just a bit of a background, medicines are the most commonly used medical intervention in Northern Ireland, and at any one time around 70% of the population take prescribed or over-the-counter medicines to treat or prevent ill health. An ageing population and increased prevalence of chronic disease increases the need for medicines, and more medication or polypharmacy leads to more difficulty with medicines management for both patients and care providers, and can increase the risk of adverse drug effects, medication errors, drug interactions, non-adherence, risk of falls and frailty, cognitive impairment, hospital admissions, and healthcare costs. A pharmacist is able to provide patient-centred medication optimisation to ensure better health outcomes through the appropriate use of medicines taken as directed. Patient-centred care leads to better informed patients who are engaged and involved in decisions about their medicines and are therefore more likely to adhere to their medication. So a referral for a pharmacist home visit is made if a member of the team have any concerns about a client's medication adherence. So these are just some examples of the reasons people might be referred, but they're not exhaustive. So if someone's maybe struggling to remember to take their medicines, they might have cognitive impairment, they might remember them in the morning but forget them before they go to bed because they feel sleepy. They might have very complicated regimens. Or they might have had their medication changed in hospital and they're just not used to the new regime yet. Sometimes clients stop taking medication due to side effects and they'll not always tell their doctor that they've done this. They might not be sure what the medication is for, or sometimes they might think it's not important, so they just stop taking it. And also we'd look at rationalising medication to fit in with other care calls. So for example, if a client was also needing help with personal care or meals, we'd try and make the medication fit in around that as well. So some data was gathered in the first year of service, and there were 291 clinically significant interventions, a 14% reduction in polypharmacy. And as mentioned before, problematic polypharmacy can increase the risk of adverse drug effects, medication errors, drug interactions, non-adherence, risk of falls of frailty, cognitive impairment, hospital admissions, and increased healthcare costs. There was a 31% reduction in anticholinergic burden. So the anticholinergic burden of drugs can be calculated using a number of online calculators. And basically, a high anticholinergic burden increases the risk of confusion, falls, and death. Higher doses, taking more than one anticholinergic medicine and being over the age of 65 can increase the risk of anticholinergic side effects. And there are annual cost avoidance and drug savings of between £33,379 to £72,436. So I just wanted to go through a case study of a lady I went out to see. She was under treatment with the reablement team. So the client had a new diagnosis of dementia, but she wasn't aware of her diagnosis and she didn't want to know because her brother had previously been diagnosed with early onset dementia. She'd been prescribed medication 4 times a day. She had poor adherence with her medication for a number of different reasons. She didn't like taking her medicine. She felt she didn't need to take medication for her diabetes anymore, as she had previously worked in a bookmaker's and she wouldn't have really ate very well. She'd have just snacked throughout the day. So she thought now that she'd retired and was eating better, she didn't need her medication anymore, but her blood results would have indicated she did still need to be taking it. And she also would have just forgotten to take her medication because of her cognitive impairment. Her medication was supplied in a pharmacy-filled compliance aid or blister pack. She was very independent and she initially refused support with her medication from staff. She did, however, agree to a trial with a memorable clock from her OT, but even with this, she was still struggling to take her medication. So the OT sent a referral to the intermediate care pharmacist. So this is her medication list. So she was prescribed 3 different medicines for diabetes, but her blood test showed that her diabetic control was poor. She was also on a medication for blood pressure and cholesterol, and she was on a rivastigmine patch for dementia. So she let her family change the patch, but she wouldn't take any tablets that her family gave her, so they were unable to prompt them. So interventions then, the metformin was changed to a modified release preparation, and this allowed it to be given once a day in the morning. Her gliclazide was discontinued. A potential side effect of this drug is low blood sugar, and this lady was eating quite erratically, so she was quite high risk of this side effect. And also, it was clear that she maybe wouldn't be able to recognise the signs of hypoglycemia and be able to treat this effectively. And her atorvastatin was changed from nighttime to morning time. So with these changes, she was now able just to take her medication once a day rather than 4 times a day. And because it was only once a day, the client agreed to let her OT request a care call once a day in the morning for medication. This meant she was still able to get out during the day and didn't have to wait around for carers. Her HbA1c, which is a marker for diabetes control, fell from 80 to 55. So her better diabetes control will reduce the risk of long-term complications. Her cholesterol also fell from 6.5 to 4.1. Therefore, it was now within normal range, and this would reduce her risk of cardiovascular and cerebrovascular disease in the future. And it also relieved worry for the client's family, as they knew she was now taking her medication correctly, as they were unable to oversee this during the day due to work commitments. And then we got a lovely care opinion feedback from this lady's daughter-in-law. So I'll have to read that. So just some other duties of the intermediate care pharmacist. So I've taken over the medication management training for our staff in the home-based services. This ensures the training is tailored towards individual services. Before, our staff would have went to generic training and they'd have been getting information about care homes and different things that didn't apply to them. It also fulfills the legal requirements for training in Northern Ireland. I also look at the development and review of SOPs relating to medication management within intermediate care and answer queries relating to medication from members of the intermediate care team. And this is just some staff feedback on the training sessions on medication management. And that's all that I have to go through on pharmacist role in intermediate care today.
Be much easier if I took myself off mute. Thank you, Sean. That was really, really helpful. And really interesting to see how it's having both an impact on patients, but the family and that wider support system, but also having that financial implication as well. Are you okay if we drop your contact details, or to drop those contact details in the chat if anybody has any questions?
Yeah, I'll pop them in now, no problem.
Amazing. And I am now delighted to hand over to Lily, one of our project managers who was also involved in the intermediate care project this year, and she's going to take us through our bed-based intermediate care findings.
Thanks, Sarah. Yeah, so today I'm going to be taking you through the bed-based intermediate care findings, as Sarah just mentioned. So to jump straight into it, firstly, I'm just going to cover the service model for bed-based intermediate care. So looking at where services are delivered, the data shows that 86% of bed-based intermediate care services that participated are provided in community hospitals, and then much smaller proportions are sort of split between acute hospitals, residential care homes, nursing homes, independent sectors, and other. The median number of intermediate care beds has remained sort of largely stable this year, from 5.3 in 2024 to 5.35 in 2025 beds per 100,000 population. In terms of share care record access, here 63% of participating services reported having access, and of these 58% have read and write access and 39% have read-only access, with 3% reporting other access level. This is important because better record access enables sort of smoother transitions and more consistent decision making across services as well. So next, moving on to frailty metrics within the service. So the data shows that 70% of services report that routine identification of frailty is done on admission using a validated tool, while 30% don't do this routinely. And when we look at comprehensive geriatric assessment delivery, 35% of services report providing CGA and 65% do not. This highlights a potential opportunity to embed more consistent frailty practice across services. And then on the sort of right-hand side of the slide, looking at some findings from the clinical case review element of the project, where organisations were asked to submit data for every service user referred into the intermediate care service during sort of the data collection period for this year's project. So 40% of these service users captured in the clinical case review were screened for frailty, 14% of patients were screened for frailty in the previous service, and 47% had no frailty screening recorded. And then of those screened in the clinical case review, 65% were identified as living with frailty. Next, moving on to access. So over the past year, the service has received 114 referrals, which works out to just under 8 referrals per week, highlighting slightly sort of higher than the previous year. And when we look across all participating organisations in the benchmarking distribution chart on screen, this shows a median of 76 referrals per 100,000 population, although as you can see there is quite wide variation sort of between services. 95% of referrals are being converted into commencement of the service, indicating that largely referrals are highly sort of appropriate and well triaged, with very few cases being screened out. In terms of where referrals come from, the clear majority continue to originate from acute settings at 73%, with small proportions of coming through community routes, GPs, emergency pathways, social care, self-referral or other sources. And the chart on the right displays that there hasn't really been much change in the pattern of these sources from 2024, and this pattern sort of mirrors the service continues to function primarily as that sort of step down function from acute care, which helps us sort of contextualize the activity levels and the types of needs services are being asked to support. Next, moving on to activity. So the main takeaway here is that service users accepted per bed have remained fairly consistent, with only a small reduction from 12.6 service users accepted per bed last year to 12.3 this year. The data shows a similar pattern for service users accepted per whole-time equivalent in post, decreasing ever so slightly from 7.1% last year to 6.4% this year, or not percent, sorry, service users accepted per whole-time equivalent in post. So additionally, the average length of stay was 24 days, with most services falling between that sort of 21 and 31 days. And the average length of stay this year appears to be slightly shorter than what we recorded in 2024. And bed occupancy levels are averaging from 93%, with little variation between submissions, suggesting that most services are operating sort of at a consistently high utilisation throughout the year. Next, sort of looking at discharge outcomes. So the median delayed discharge rate sits at 26% amongst participating services, with most services falling between 17 and 36%. This highlights that delays remain quite a notable challenge across the pathway, and contextualise sort of the wider flow pressures experienced by services, as delays at this stage can sort of limit bed availability and slow the overall throughput of intermediate care pathway. Looking at destination on discharge, 64% of patients returned to their usual place of residence, which is an improvement from last year's 55%. So this suggests a continued sort of positive trend in supporting people to return home, helping contextualise the effectiveness of the service in maintaining and restoring independence. Smaller proportions were then discharged to residential or nursing homes, to acute hospitals or to other locations, with a small sort of proportion recorded as not known or not recorded. And together these figures show both progress in more people returning home, but also that continued pressure around delayed discharge. So continuing on with discharge, and these findings on screen are from the clinical case review, focusing on changes in care needs and whether goals were achieved. So firstly, looking at goal achievement on the left, 47% of service users met the intermediate care goals that were set at the start of the service. This is lower than last year's figure, where this was 68% amongst the sample. This metric demonstrates that this year that almost half of the patients sort of achieved their intended outcomes. And then next on the right hand side, 61% of service users were discharged with no change or decreased care package. A quite significant increase from 2024, which shows that the service is helping people maintain or improve their level of independence whilst in the service. Together, these figures give us a picture of a service that is largely stabilising the care needs, with just under half of those patients achieving their planned goals. On this side, we're looking at outcomes measured through the modified Barthel score, and we're also looking at harm from falls too. So the modified Barthel score is a tool used to assess the degree of independence a patient has in performing activities of daily living. So a higher score indicates greater independence and a lower score indicates increased dependency. So the data shows that patients entered the service more dependent this year than in the previous couple of years, but also experience sort of the biggest improvement in independence that we've seen over the last few years. So even though that they are leaving the service slightly more dependent on average compared to last year, their overall improvement during their stay is greater. We also see a slight reduction in harm, with the rate of falls decreasing from 3.4 per 100 service users down from 3.8 the previous year. On this slide, we're looking at patient-reported experience measures. So 91% of users were aware of the care aims that the service was working towards. We also see overall a relatively strong levels of confidence, with 88.9% of service users saying that they definitely had confidence in the staff supporting them. In terms of communication and involvement, 76.5 felt that they were given enough information about their condition or treatment, and 94.5 agreed that they were as involved in their decisions about their care as they wanted to be. So overall, these results show sort of consistently positive patient experience across sort of those key areas, which is really nice to see. On this slide, we're looking at the workforce profile. So the median service had 15.4 whole-time staff in post per 100 new assessments. The data shows that the workforce is predominantly nursing, making up about 74% of all staff in post. We can also see a median vacancy rate of 12%, which has increased from 8% last year, highlighting a notable gap between in-establishment and in-post figures, with the highest vacancy rates seen in medical and nursing staffing, as shown on the chart on the right-hand side. Alongside this, 15% of total pay spend is towards bank and agency staff, which indicates a potential reliance on temporary staffing to maintain sort of those service levels. On this slide, we're taking a little bit more of an in-depth look at the nursing staff discipline mix and band mix within bed-based intermediate care. So the breakdown shows that registered nurses make up around 43% of the nursing workforce in post, and unregistered nursing staff account for about 55%. And then smaller proportions are made up out of advanced nurse practitioners and nursing associates. And when we look at band mix, we can see quite good representation across the nursing bands, with bands 3 and 5 featuring most strongly. And then on this slide, we're looking at some of the staff survey findings. So positively, 100% of respondents agreed that their role is making a difference to patients, which really highlights the strong sense of purpose within these teams. We also see positive views around safety, with 94.5% of staff agreeing that their organisation has done enough to ensure their safety at work. However, the survey also reflects the pressures that staff are working under, with 76.4% saying that working in intermediate care has affected their work-life balance and emotional well-being. And then finally, 76.4% of respondents felt that their service integrates well with other healthcare services and departments, showing generally good collaboration across the pathway. And then my final slide is on finance. So the chart on the left of the slide shows the comparison between direct costs budget per service user accepted, which is £9,800, and the direct costs actually spent, which is £10,200. So this suggests that the average service is spending slightly more than what their planned budget accounts for. And on the right hand side, we can see the breakdown of the direct costs. So on average, 92% of direct costs relate to pay spend, while 8% relate to non-pay costs. So this high proportion of pay spend reflects the staffing intensive nature of intermediate care. And that draws me to the end of those findings.
Fab. Thank you so much, Lily. There's no questions currently in the chat, but if anybody does have any, please feel free to drop them in. I'm delighted now to be able to welcome Kevin Fisher from Norfolk Community Health and Care NHS organisation, who is going to take us through how they've used benchmarking over at Norfolk. Kevin,
Hi, good afternoon. Thanks, Sarah. Thanks very much for the introduction. Good afternoon, everybody. So this is a very short presentation. I'm conscious of time, but a short presentation just to give you a bit of an overview of some of the things that we've used benchmarking for, in particular in our community bed-based intermediate care section within the organisation. I'm stepping in on behalf of a colleague. My colleague, Katie Robinson Sherlock, was going to deliver this presentation today. Unfortunately, she's not in work. So this isn't my slide deck, so I'll apologise in advance. I'm sure you can all appreciate it's always sometimes slightly difficult when you're using a slide deck prepared by somebody else, but hopefully you'll all get the gist. I know we don't have a great deal of time left. I'm more than happy to take questions at the end, but I'm equally also happy if anybody wants to get in touch with me after this, if they've got any queries or questions or would like to ask anything about what we've done with regards to what I'm going to show you this afternoon, please do feel free to get in touch. So, as I said, we're just going to talk to you very quickly this afternoon about how we've used some benchmarking data inside our intermediate care service. Just to give you a little bit of context, our intermediate care beds are under a fair bit of sustained and increasing pressure. As you can see from the bullet points on the slide, in the last 12 months, we've seen our community access team referrals up 37%. But our CAT team are the conduit between acute trusts and our generalist inpatient units. We've seen demand for our rehabilitation beds up near 46%. We've seen our patient flow in terms of admissions and discharges up 26 to 27%, and our occupancy sits consistently at around 98 to 99%. On top of all that, we are seeing more patient complexity in terms of that rising. We're supporting more bariatric patients, more one-to-one requirements, and of course, the whole thing around complexity, frailty, and acuity just going up, and it has such a huge impact potentially on staff in terms of that demand and capacity. So for us, benchmarking isn't something that's theoretical. We try and use it as a way to understand whether what we're seeing is local pressure, can be explained that way, or something that's a national pattern, and what we can actually do about it. Now, in terms of what benchmarking told us, one of the first things we looked at in a bit of detail was the average length of stay. We could see from our own data, going back to 2023, our average length of stay was 36 days. The year after, we managed to get it down to 28, and the year after that down to 27. But what the NHS benchmarking network report showed us was really useful, showing that the national median average length of stay is 24 days. So we were quite away from that. So although we had made some improvements locally, the benchmarking showed us that we had improved, but we hadn't gone perhaps as far as we could, and that gave us the opportunity to change the conversation from patting ourselves on the back a little bit, but actually been a bit more curious about why. The real reason wasn't clinical length of stay. Our actual clinical length of stay is 19 days, but our reported total length of stay, 27 to 28 days, and that gap is actually the non-criteria to reside. Something we used to all call it delayed discharges, but that's the gap that we saw. Benchmarking showed occupied bed days utilised by patients meeting the discharge criteria, having a median of 25.5%, and in 24-25 we were sitting at 37.3. So quite a way to go for us, and that's when benchmarking stopped just being descriptive, but started to become a little bit more diagnostic for us. So because we could see this wasn't just a thing of how intermediate care is, we took some action. We recruited some additional resource in regard to a discharge coordinator. We increased resources in line with our community access team model. We did some other things around earlier frailty identification and working with frailty hubs and our virtual wards. And we also looked at doing more joint MDT assessments to avoid sequential delays. And the impact of that, pleasingly, is we managed to get down from 37.3% non-criteria to reside down to 29.4%, which I think just below the national benchmarking threshold of 29.5%. So, you know, we can see that's a direct line from benchmarking, go through operational change and resulting in a measurable impact. It also helps us understand something else. Now, we relatively recently opened a new rehabilitation unit, our Willow Therapy unit, and opened with 48 beds, and we had an average length of stay of just under 22 days. So Willow wasn't just extra capacity, it's actually a flow accelerator. Willow now accounts for 30% of our admissions, and one of the reasons that we can run somewhere between 200 and 220 admissions a month, all at the same time as keeping our average length of stay stable. And that insight is how we think about future modelling of our beds. Just quickly on demand, occupancy and the potential hidden risks. So when we looked at our community access team data year on year, we found that in 2024, 51% of our access team demand was admitted. In 2025, it was gone up to 56%, actually equated to 67 more patients a month needing a rehabilitation bed. And we also, comparing ourselves to the benchmarking data, we showed that we sit at 98 to 99% compared to a median occupancy rate of around 93%. So knowing that helped us to articulate, to our senior leadership that we're actually operating above the level that most systems run at, and that's why a relatively small issue like a therapy absence or social care delays can have a disproportionate impact, particularly on things like average length of stay. So what it helped us do is to provide us with that language and data behind it to describe the operational fragility that we know the service is experiencing. Benchmarking has changed the conversations that we have in three ways. So we don't kind of just say anymore we're just busy, but we think of ourselves more of actually we're an outlier here. We don't say this feels slow to actually delays are our system issue, and we don't just say we need more beds. We say we need better flow, because obviously the better patient flow we have through our units, then the more patients we can see, and the more that we can then cope with demand. It's helped us have more evidence-based discussions with colleagues across social care, across the acute trusts, our frailty hubs, workforce planning, and of course our colleagues in the commissioning world. And just finally, I think this is just about the last slide, nearly. Maybe we'll get a couple more to go, but just in terms of where we're going next, we're using benchmarking data to focus on frailty screening and comprehensive geriatric assessment rates, patient reported experience measures, involvement in discharge timing, workforce sickness, vacancy comparisons, etc., and occupied bed days utilisation for discharge ready patients. And that's because, primarily, through the work that we've done and utilising the benchmarking data, we now have a much better idea of where we should actually be looking. So just very briefly, in summary, benchmarking in 3 days has helped us reduce our average length of stay. In 3 years has helped us reduce our average length of stay by 9 days. It's reduced our delays by 8%. We've increased our patient flow and throughput by 27%, and that's enabled us to absorb 37% more demand, which is really good. I think that is the end of the slide deck. It is. So apologies for running through it. As I say, I'm conscious of time, but obviously they're not my details on there, but Katie will be equally as happy as I am. If anybody has any queries, please do feel free to make a note of that. All my details, I'm happy for the benchmarking network to share those. But I hope that was useful. And of course, if anybody has any questions, then please do feel free to ask.
Thank you so much, Kevin. There have been a couple of questions in the chat, but Vanessa's also on the call, so she has been answering those for you.
Excellent.
So that's really helpful. And it's really nice to see how you can really turn the benchmarking to life and make it drive that improvement, which is what we're ultimately here to help and support. We do actually only have 4 minutes of the session left, so I am just going to run through a little bit about how you can really turn that benchmarking to life and what you can do with those bits. So for all of you that have participated in the Intermediate Care Project this year and where your organisation has agreed, we have the show code functionality, which you can see on your screen now. So you can go on there and you will be able to access those contact details of anybody that has participated. So as Kevin said, if you are an outlier or you want to speak to an outlier to understand what's going on, please do that. We are the benchmarking network. We're not just here to benchmark, we are here to help facilitate networking. Another really useful resource is our shared learning compendium, which there is a screenshot on there. Again, anybody can access that. It is a member of the network, and it does share some really useful information around what's being done in other areas of the UK, which is really helpful to drive that shared learning. I just want to take the last 3 minutes to firstly thank all the members that have joined today and non-members, all the members that have taken time to participate in the benchmarking exercise, and also the team that have worked really hard behind the scenes, not just to pull this session together, but to analyse all of the data to be able to play it back for you. And my final plug of the day is, if you haven't already, please go and log in to the members area, have a search around, because we have really only skimmed the top of the data today and there is so much there. And my final thanks is to all the presenters today that have taken time out of their day to share either what they're doing in the intermediate care space or how they are using the data to drive those improvements. Thank you so much, everybody, and we will give you 2 minutes back into your very, very busy day.